My name is Robert Sorabella. I'm a fourth-year resident in cardiothoracic surgery at Columbia University Medical Center and New York Presbyterian Hospital. We looked at outcomes following valve replacement surgery in patients with endocarditis who were complicated by cerebral embolic stroke, preoperative cerebral embolic stroke, with the goal of comparing those patients' early outcomes with patients who had no preoperative stroke. And we found that there was, at 30-day, no difference in mortality as well as no difference in postoperative stroke rate between the patients who had a preoperative stroke, embolic stroke, important distinction, and patients who had no preoperative stroke. So to give a little background to answer the question as to why we decided to study this area, the traditional approach to patients with a preoperative stroke is to delay surgery, valve surgery, for 4 weeks prior to intervening in order to give the peri-infarct tissue time to heal and theoretically prevent hemorrhagic conversion. So if you see a patient in consultation and they are completely stable and able to wait that 4 weeks, that's fantastic, and they likely should wait the 4 weeks. But we found a more common occurrence is that patients need the operation and can't wait 4 weeks. So that was what spurred us to study the outcomes in patients who really need that operation prior to the 4 weeks and determine if their postoperative stroke rate is higher or their mortality is higher. So anecdotally, our experience, we were not expecting to find a big difference in the stroke rate. The literature from 20 years ago or so that it kind of determined the vague guidelines on waiting 4 weeks had neurological deterioration rates in the 20 to 30% range at 2 weeks after the diagnosis of the stroke. In our practice, we were not seeing that, and so when we found that the stroke rate was not significantly higher, I don't think we were that surprised, although we were excited to find that the stroke rate was minimally higher in the patients who had a preoperative stroke. It was 9% stroke rate in the preoperative stroke group compared to 5% in the non-stroke group. A couple other groups have actually studied this and have similar findings. So we were enthusiastic that our results were along the same lines of the other groups, and I think that's very good for patients who present with a preoperative stroke. Up to 50% of patients with endocarditis can present this way, and so it's good to find out that if they need surgery, they can undergo it without dramatically increasing their stroke rate. The take-home message from our study and the way we hope that our results are incorporated into practice is that when you see a patient in consultation with endocarditis who has a preoperative stroke and needs an operation, you can be reassured that you're not dramatically increasing their risk of postoperative stroke and disability rate and mortality rate. According to the literature from 10 and 20 years ago, that was a major concern, and I think when we come across these patients, frequently the same events happen. We see the patient, decide that they probably need an operation. They have a significant indication, valvular regurgitation, persistent bacteremia, an annular abscess, and then we decide that we should call neurology, certainly, to consult, and neurology kind of has their hands tied because they know that there may be a slightly increased risk, but also that the patient may need that operation. So I think our study helps to kind of delineate that situation and reassure us that it is probably okay to operate on these patients earlier rather than wait 4 weeks. Most of the studies in this area are a small series, and because we found, as well as other groups have found, that the event rate is low, it's difficult for us to determine predictors of which lesions may be at particularly high risk of hemorrhagic conversion. So I think that the next big step in this area is to pull together lots of centers' data and see if we can determine lesion characteristics that might push us even more to wait the 4-week waiting period as opposed to operating early, whether that be lesion diameter or location Those variables remain to be seen, but I think that's certainly the next step. The other area that we can investigate is we looked up to 14 days. That's what we determined to be early surgery. At the STS, when I presented the talk, I was asked a question, which I think is a good one, and that's, what about, is the risk higher at 3 days? Is it higher at 5 days? We had 54 patients in our stroke group, so it makes it a little small to be, to divide each patient, a time window. But with more patients, certainly we could potentially find that, yes, the risk is higher at 3 to 4 days. So if you can wait even 2 or 3 days before proceeding to surgery, that may decrease your risk of postoperative stroke.